I don't have any disclosures for my talk. Now, before I start talking about the therapeutic drug monitoring, I would like to know, like, how many of you are actually using in your clinical practice? Just raise your hand. Wow, great. Why we need a therapeutic drug monitoring, especially when we are talking about antifungal? So reason is that, I mean, we know that most of the azoles, they have the intra-individual variability in their pharmacokinetics and pharmacodynamics. And that's the reason that we need to, I mean, identify the patients are achieving adequate therapeutic levels of these drugs because it directly related to either toxicity or to the success of your antifungal therapy. The azole has the Ben Hock has clearly shown that, I mean, azole has significant drug-drug interactions, and he has shown the examples of vincristine with the azoles, and the patient had toxicities, right? So these drug interactions may lead to the either overexposure of the concomitantly used drugs, or it may reduces the level of concomitantly used drugs and produces the lack of clinical response. So the drug-drug interactions are another important area where we need to do a TDM of these antifungal agents. So which drugs, like, we will go for the therapeutic drug monitoring. So here, like, you should remember the two clinical scenarios. One, the antifungal drug which has got the peculiar the characteristics, and the second is the patient's clinical scenario where you are going for a therapeutic drug monitoring. So when we talk about the antifungal drug properties, when the drug has a well-defined the exposure and the response relationship, right? So when we know that if you are going to achieve the X level of your antifungal therapy, then you are going to get a good clinical response. Or when you have a good the exposure and the MIC, so AUC upon MIC, the relationship, then obviously you are going to check the drug level that your patient is achieving just to predict that your patient is going to do well on your the dosage that you have recommended to treat that particular fungal infections. The another important characteristics of antifungal therapy that we generally look for the TDM is the drug which has got a narrow therapeutic index. So meaning that, like, the response and the toxicities are very narrow. So when you are looking at the level of the drug which produces the good response, and just above that, like, when you are expecting toxicities, the good example here would be voriconazole. We know that the therapeutic levels of voriconazole expected is 1.5 to 4.5. So but when your patient is having the level of more than 5, then we expect variety of neurological toxicities, hepatotoxicities, and the other toxicities. So these drugs requires the TDM. The drugs which has got a substantial pharmacokinetics variability, and this could be the absorption, this could be the metabolism, where you are going to check the TDM. Like, again, taking an examples of voriconazole, where we know that the metabolism of voriconazole is mainly by the CYP2C9, and to certain extent it will be metabolized by the 2C19, and we know that there is a genetic polymorphism, and which is different for the different people. So the metabolism or the handling of the voriconazole would be different in this group of the patients. And atraconazole, the absorption is highly erratic. When you use a capsule versions of atraconazole, the absorption is highly erratic. So here we need to check the levels of this drug. Uh, the patient's clinical scenario where we generally prefer to check for the drug levels are the patient who has either hepatic or the renal dysfunctions. Here, like, we know that most of the drugs are eliminated by either liver or the kidney. And when somebody has this organ damage, the pharmacokinetics of these agents would be affected. So we need to check for the drug levels in these situations. The extremes of the age and the weight of the patient. So very high weight obese patients, I mean, generally we'll try to, because here the drug dosage are not exactly the weight based, like somebody weighing 130 kg, 150 kg, then here, like, we need to check for the TDM of these patients. And for the extreme age, we know that, like, I mean, the patient who are either very young, the metabolism is different, and for the very old patients, because of the organ damage, organ dysfunctions, the levels could be different. So these are the two another clinical scenarios where we generally check for the TDM. The another very important or interesting clinical scenario would be just to check the compliance. So when you are providing the appropriate antifungal therapy, your patient is not responding, and you doubt that patient is not consuming. So just to check the adherence, you may subject these patients for TDM to find out like whether patient has achieved adequate level or not. So adherence assessment is another indications for the therapeutic drug monitoring. The another important clinical scenario that becomes little, in the discussion in clinical science is treatment of the organisms which has got little higher MIC level. Here, like aim is to treat the difficult to treat infections like the Scedosporium fusarium or the mucormycosis, where you expect very high MIC of your azole antifungal therapy. So here you are going to end the sanctuary site infections or the patient with the brain infections, where the drug penetrations would be a little less as compared to the other organ system. So in this situation, your aim is to keep little higher the therapeutic levels of this antifungal therapy to target those fungi which has got the higher MIC or the fungal infections into the sanctuary sites. And the drug interactions, obviously, like that is what we, generally look for. So when you expect the drug interactions affecting the azoles, like patients are receiving the enzyme inducers, which the drugs which can induce is the CYP3A4 system, where the most of the antifungals are metabolized. Here, the situation you are going to check your the antifungal drug levels just to make sure that patient has achieved adequate levels. So now, with this background, like let us take the real clinical scenario, which is this patient is currently under our care. So this is a 73 years male residing into the northwest states of the India, and he is a farmer, no travel history, and no comorbidities. So he do not have any other medical issues. And he was well before 3 months of his presentations. He came with the cough, progressive weight loss of 18 kg and weakness. So these were the only 3 symptoms. Then he started noticing the difficulty in chewing since last 2 months, and develops nodular skin lesions started from the forehead, which rapidly progressive and involves the entire forehead, face, limbs, back, and the axilla in last 1 month time. And now he had a new onset fever since last 10 days. And this was his the lesions over the forehead and the face. Vitals showed the blood pressure was 104/58, and there is a postural hypotension of 6 millimeter of mercury in the systolic blood pressure. There were multiple nodular gums lesion, and that's the reason that he was unable to chew food. And there were firm hepatosplenomegaly. Liver was 5 finger palpable below the costal margin, and the spleen was 4 finger palpable below the costal margin. So with this 3 months history of some respiratory complaints, weakness, and weight loss, he had massive hepatosplenomegaly, and which was formed. The patient was worked up at another hospital with CT scan, and which showed 2 pleural base, a small nodule, and rest was unremarkable. His HIV and hepatitis B were negative. The skin biopsy was performed at another place, and it showed multiple the organisms yeast within the cells and outside the cells, which is suggestive of histoplasmosis, and that's the reason that patient was referred for the further treatment. So we started him on standard liposomal amphotericin B 3 milligram per kg, and at the same time, we have also put him on itraconazole just to make sure that patient achieved itraconazole level when we stop liposomal amphotericin B therapy for 2 weeks time. So standard itraconazole was given 200 milligram 3 times a day for 3 days. That is the loading dose, and followed by 200 milligram twice a day. Look at the levels. So the still patient is on amphotericin B. So on day 8, we know that the patient generally takes 5 to 7 days to achieve a steady state level of itraconazole. So despite loading dose of itraconazole for 3 days, the first TDM that we did for itraconazole was the itraconazole level was 0.064 and the hydroxyitraconazole was 0.19. We know that the first metabolite of itraconazole, hydroxyitraconazole, is also very active antifungal agents. So we generally calculate both the and check for the levels. So it was highly suboptimal. Fortunately, like in India, we have the itraconazole superior bioavailability versions available. So we just changed the itraconazole superior bioavailability to 300 milligram twice a day. So we just increased the dose from 200 to 300 and we changed the formulation. So repeat the TDM was, there is some improvement, but it is still suboptimal level. So we changed the drugs to the posaconazole and it was undetectable. So we have again switched back to the itraconazole superior bioavailability. Now the dose that we use 300 milligram 3 times a day. And the patient is doing great. So patient has achieved therapeutic levels and then we continued the same. So this is how like you can tailor-made the need of your antifungal therapy to treat your systemic fungal infections. Now coming to the another important agents, voriconazole, which is again very commonly used drugs for the treatment of invasive fungal infection, especially the aspergillosis. But I mean this drug, we know that I mean it is metabolized primarily through the CYP2C9 and 2C19, which is having a genetic polymorphism. So routine therapeutic drug monitoring for voriconazole is highly recommended. Because of this genetic polymorphism, there is a significant interpatients pharmacokinetics variability, and especially in adult patients, when you are treating adult patients, it has got a non-linear pharmacokinetics, meaning that if you increase the dose of voriconazole, you do not expect similar increase in the level of your voriconazole. At the same time, when you are decreasing the voriconazole, you do not expect the similar decrease in the blood level that you are going to achieve with the reduction in the dose. So it is highly unpredictable drug exposure in adult patients. But in pediatric patients, it has got a linear pharmacokinetics. So that is dependable. But in pediatric patients, the absorption of the drug is little less as compared to the adult patients where more than 90% there is a bioavailability of voriconazole. But in pediatric patients, it is up to 60 to 65%. The GI absorption of the voriconazole is affected by the food. So if your patient is consuming food along with the voriconazole, then there is up to 22% decrease in the voriconazole bioavailability. So generally, it is to be consumed on empty stomach. So I mean, food can also affect the level of voriconazoles, and that's the reason that we need to look carefully into the TDM. Apart from this, like there are various drug-drug interactions because all these azoles antifungal therapy, they are potent inhibitors of CYP3A4, and this enzyme is responsible for the metabolism of the most of the drugs. At the same time, apart from the inhibitory effect on the CYP3A4, these azole drugs, they also affect the P-glycoprotein channel, and this is a efflux pump. So by inhibiting the P-glycoprotein or the PGP, it also increases the exposure of the drug, which also utilizes the same channel for the transportation. So the drug exposure is increased by two mechanisms. One is inhibition of the CYP3A4, and the second mechanism is inhibition of P-glycoprotein. So all these things, like I mean, make it very complex, and you need to look into the actual drug level that your patient is achieving. We also talked about the AUC-MIC ratio when we introduced like TDM looking at the drug property. So we know that like when you have achieved AUC-MIC of more than 25, and that's the reason that we give little higher dose when we expect that MIC of the antifungal is very high or difficult to treat infections. So AUC-MIC of more than 25 is associated with clinical efficacy when voriconazole is used to treat the Aspergillus and the Candida. And this is how you can tailor-made the dose for that particular patients to achieve AUC-MIC of more than 25. There are various studies which showed that when you are doing the therapeutic drug monitoring of voriconazole, the patient who underwent the TDM, they have very high chance of complete or the partial response as compared to the patient who did not receive TDMs. And this is 81% versus 57%. So the British Society recommends the trough level of more than 1 to keep between less than 4 to 6 microgram to maximize the effect of antifungal activity of voriconazole. So this is a drug where you need to monitor very carefully because of the several factors which affects the pharmacokinetics of voriconazole. And this is another study that, this is again very old study, but it clearly shows that when the voriconazole level is less than 1, you can see that there is higher proportion of the patient who did not get a clinical response as compared to the patient who achieved more than 1, right? So this is again very important to predict a successful outcome of your patient's treatment. Now coming to the another antifungal agents, that is posaconazole. So need for the posaconazole TDM is highly dependent on the formulation that you are using to treat your patients. The POSA suspension, the initial the formulation, which has got the significant the impact on the absorption. It has got a saturable absorption leading to the highly variable bioavailability. So you need to give a frequent dose of posaconazole suspension along with the fatty meals just to improve the absorption. And at certain dosage, you cannot improve the posaconazole absorption beyond when you are using it for treatment of invasive fungal infection. Then that was the most important limiting factor of using posaconazole suspension, especially when your patient is having some GI the issues like the hematology patient who has severe mucositis, severe diarrhea, and the patient who has GI, the other anatomical issues where the posaconazole absorption is affected greatly and leads to suboptimal exposure of this drug. The absorption of the POSA suspension, as we talked that, I mean, it increases with fatty meal and the gastric acidity, right? So it is affected by the acid reducing substance also. But the newer formulation, the intravenous formulations as well as the delayed releasing tablet version, it has got a significant improvement, especially the bioavailability is concerned. And all these factors that we discussed probably will not affect greatly to the POSA absorptions and POSA exposure. Similar to the voriconazole, we have, I mean, good studies available for the posaconazole TDM and the successful outcome, and it has shown the same thing for when we are using a posaconazole for prophylaxis as well as when you are using posaconazole for a therapeutic for the invasive fungal infection. There are certain conditions, like especially when you are treating the drug-resistant fungi or the difficult to treat fungal infection, the higher posaconazole level. There are studies where they have kept the posaconazole trough level more than 3, and they have successfully treated this resistance fungus, which includes the aspergillus, which is resistance to the azoles. So all these Scadosporium, Fusarium, and the certain Mucorales species where the MIC is high, you can keep the POSA level higher and try to give the treatment of these difficult to treat fungal infections. The general recommendation for posaconazole for the treatment of invasive fungal infection is more than 1 microgram for a primary therapy, and if you are using it as a salvage therapy, try to keep it at more than 1.25. But up to 3 has been recommended for treatment of this resistance fungi. So the advantages of the drug tablet versions or the delayed releasing the posaconazole tablet is that the once daily administration as compared to the suspension, which requires a frequent administration for a loading dose and then twice a day. So this drug can be given as a once a day after giving a loading dose of posaconazole on day 1. It can be consumed regardless of the food. So the patient who has some GI issues, like they can also consume the posaconazole tablet. There is a less interpatient pharmacokinetic variability as compared to the suspension, and it achieves very high and consistent posaconazole level as compared to the suspension. So this is, I think, one of the very important advantage of using posaconazole tablet, that it achieves a high and the consistent plasma level. The absorption is not greatly affected by the gastric pH and the motility, but yes, so if you are using a proton pump inhibitors in a higher dose and the GI prokinetic drugs, you may get the less exposure of posaconazole. So be careful when you are using posaconazole in your patients. And there is a better the systemic availability, and it achieves early steady state level as compared to the posaconazole suspension. Generally, the posa suspension takes 7 days to achieve steady state level, but posa tablet will start achieving steady state level from day 3, 4 onwards, right? So you will achieve early steady state level. There is a theoretical advantage of achieving early steady state level is that your patient is having an appropriate exposure of the drug from day 3, day 4 onwards. So that's the reason that you may expect early antifungal activity with these posaconazole tablets and the intravenous formulations. The another, the azoles which is also available for the treatment of IFI is isavuconazole. And isavuconazole is, I think, I'll say that, I mean, it is exactly comparable to fluconazole, especially when you talk about the pharmacokinetics property. Fluconazole is an ideal antifungal drug as far as the PK concerns, right? So it has got linear pharmacokinetics. It has got the MIC level you can predict from the dose of the fluconazole, and it has got the predicted AUC or the area under the curve of fluconazole depending on the dosage. So it has got a very ideal pharmacokinetics parameter, and the isavuconazole is also comparable. It has got a linear pharmacokinetics, and you expect the exposures of isavuconazole just like fluconazole. So in this study, like they use the isavuconazole, the trough concentration, and they check the daily dose with loading dose and daily dose without loading dose. So those patients who received the loading dose, they will achieve the early the steady state level as compared to those patients who has not received loading dose. And that's the purpose that we are using generally loading dose of fluconazole, voriconazole, itraconazole, and isavuconazole to achieve early steady state level. This is the isavuconazole, concentrations in the real world practice. So looking at this, the predictable pharmacokinetics of isavuconazole, in general, the therapeutic drug monitoring of isavuconazole is not recommended for treatment of invasive fungal infections, except in some specific clinical scenario like resistance fungi. Patient has some the clinical medical disorders like renal failure, hepatic dysfunctions, or any other things which can affect the absorptions and the eliminations of the drugs, where you may check for the isavuconazole and the sanctuary site infections like the CNS infections, where you may check the trough level to make sure that patient is having adequate exposure. So in real world scenario, they found that, I mean, most of these patients, right? So those patients who has received isavuconazole for the treatment, like they achieved the adequate therapeutic drug level as compared to in clinical trials, right? So in real world, like 283 patients and almost 2,400 patients in the clinical trials, the mean the levels or the mean exposure of the isavuconazole is almost similar, right? So isavuconazole probably generally do not require a frequent TDM except some clinical situation where you may attempt to do TDM just to make sure that it's a good exposure. The another antifungal drug which requires the TDM is 5-flucytosine. Unfortunately, it is not available in my country. We do not have an access to the TDM for 5FC, but this drug do require TDM, especially when somebody has the impaired renal functions, right? Because here the exposure of the 5-flucytosine increases and it may end up into the significant toxicities, especially the hepatotoxicity and the bone marrow toxicities. And we know that it is generally used for the treatment of cryptococcal meningitis along with the amphotericin B, and it has got very narrow therapeutic index, right? So the effect goes away when the level is less than 30, and if you cross more than 100, milligram per liter, then you may end up with the bone marrow or the hepatic toxicities. It is mainly excreted by the kidney, so it is very useful for the treatment of the renal infections also. And there is, because of 90% is excreted into the kidney, so a patient who has impaired renal functions, you expect accumulation of the 5-FC into the systemic circulation, and you may end up with the toxicities. So the patients can get variety of toxicities, which include the simple toxicities like the GI disturbances, nausea, and the diarrhea, to life-threatening toxicities, which includes the bone marrow suppressions or the blood dyscrasias, and patients can get the hepatotoxicities and hepatitis. So TDM is generally not necessary for the amphotericin B because we know that it's going to accumulate into the tissue, and the tissue half-life is more than 3 weeks. So you do not need to do a TDM for amphotericin B. Fluconazole has a very ideal pharmacokinetic property and predictable exposure. So this drug also do not require the TDM, except when patient is receiving augmented renal replacement therapy, right? So when patient is having the CVVHD, CRRT, where you expect the increased exposure of fluconazole and your patient requires fluconazole, in such situation, probably you may do the therapeutic monitoring for fluconazole where patient is on augmented renal replacement therapy. Isavuconazole is also just the PK is similar to fluconazole and you do not require it. And for echinocandin also, generally the dose, recommended dose is sufficient to treat most of the candida infections. Now the important clinical question comes like when you are going to collect the blood for the therapeutic drug monitoring, right? So we need to understand that we are looking at two levels. One is the peak level and the second is trough level. So for azole therapy, like we generally look for the trough levels. So trough levels are the levels where you are administering the medications, and before administration of the next dose, you are collecting a level to make sure that patient has maintained the level well above the MIC of that particular minimally concentration, right? So trough level is the drug blood that you have collected just before the next dose, and the peak levels. Generally, we do peak levels for the anti-TB therapy, that is isoniazid, rifampicin, and pyrazinamide. And for 5-flucytosine also, we also looked at the peak levels. So peak levels are the levels that we collect the blood after 2 hours of consumptions of the medications. And we just look at the exposure of the drugs after 2 hours, right? So this is where you collect the blood. And the one word about the steady state level, because once you start administering drug to a patient, it's not that very next day patient is going to achieve the adequate therapeutic levels. And depending on the pharmacokinetics of the drugs and the absorption and the GI, the concerns of the drugs, the patient will have some levels. Again, it will go down levels, and patient will take certain amounts of the day before the patients can have a steady level of the drugs into the plasma. So this is what we call as a steady state level. So generally most of the antifungal drugs will take 5 to 7 days to achieve a steady state level. So generally when you have initiated your antifungal therapy, we know that we are going to take a trough level for azoles, and we should also know the steady state level. So most of the time, like after 5 to 7 days of starting antifungal therapy, we order for the trough levels at the time where the patient has achieved a steady state level. So this is a summary of TDM. So flucytosine, we generally look for the peak levels, and these patients will going to achieve peak levels at 3 to 5 days time. And we know the goal of the treatment, try to keep less than 100, and more than 100 would be the toxicities. Itraconazole will take 5 to 7 days to achieve steady state level if patient has received loading dose, or you can delay it by 10 to 14 days when patient has not received the loading dose. And the the standard recommendation is try to maintain between 1 to 2. So if your patient is having a very high level, then you may end up with the mineralocorticoid excess type of toxicities of itraconazole. The main important side effects are the gastrointestinal, but very high level and the prolonged therapy may end up you into the mineralocorticoid excess, where patient can have hypertension, patients can have hypokalemia, and the other features. The voriconazole, that we generally go for a trough level after 5 to 7 days of exposure, and the therapeutic levels is between 1.5 to 4.5. So keeping more than 5, you should be very careful because it will end up with the CNS toxicities, hepatotoxicities, and the neurotoxicities. The POSA suspension will take 7 days to achieve steady state level, so where we generally do after 7 days, but for tablet versions, you may do it at early. And the target is keeping more than 0.7 for prophylaxis and more than 1 for treatment of invasive fungal infections. So take home message from this talk on TDM. We should have a pragmatic approach for antifungal TDM. This is very important because TDM will help in individualizing antifungal therapy, and it is associated with the improved clinical outcome and reduced toxicities. For example, like in our patient, like patient has, despite adequate dosage of itraconazole, patient has not achieved itraconazole level, right? So once we stop amphotericin B and continued on the itraconazole, patient might not achieve the level, and patient can have treatment failure and the disease progressions. So, I mean, the incorporating TDM into the clinical practice has immense value. So TDM will be useful in certain difficult to treat situations also, like when the site of fungal infection is in the sanctuary sites like central nervous system, where the blood-brain barrier is a major the limiting factors for entry of the drugs. So here, like keeping a high level, expecting more CNS penetration is one clinical scenario where one would like to use TDM. The fungal pathogens which has got a higher MIC like Mucorales, Scedosporium, Fusarium, where you also try to keep a higher MIC and monitored by the TDM. The antifungal susceptibility showing a resistance fungi, especially the Aspergillus resistance to the azole with high MIC. You may use a drug with keeping a very high levels. The other factors which can potentially affect the pharmacokinetics of your antifungal therapy, like drug-drug interactions, absorptions issues like mucositis, diarrhea, patient is having end organ damage like liver and the kidney dysfunctions and the morbid obesity. So these are the situations where you also use TDM for treatment of your difficult to treat patients. Thank you very much for the patients listening.